It's a pleasure to have you back again after quite some time, and I apologize that we haven't been able to do the conceptual base course in the last 2 or 3 months, actually, uh, engaged in so many other things. But we are back, and I've received quite a few requests from all the colleagues about the topics that they wish to cover during these conceptual base course. So we are back again, and I'm very fortunate again to have Dr. Ananda Kumar. He is very well known to all Pakistani delegates, and it's a world authority on benign prostatic diseases. So what we are going to do is talk about the male lower urinary tract symptoms. The male tract evaluation is what I'm going to do, and Dr. Kumar is going to talk about the treatment selection. And we know that there's so many things available now that it's really difficult to make the right decision. Horses for the courses approach is probably what is required. So Dr. Kumar, with his vast experience in both the conventional ways of treating BPH versus some of the so-called mist, he's an expert in all these, and he will guide you to make the right decision. My talk is very basic. I'm going to talk about male LUTS evaluation. I have no conflict of interest related to this presentation. I must emphasize, particularly to our junior colleagues, that although we have we have such a great tools available now in terms of various investigations, what is extremely important is a good history and physical examination, and that you cannot really supersede with anything else. With everything available, still evaluation of the male lower urinary tract symptoms with a good history and physical is the first step. And particularly important is to conduct the lower urinary tract symptom questionnaires and quality of life assessment. Bladder diary is something which will save you from unnecessary tests on these patients. So if you do a bladder diary and you come to know that it is only related to the kind, the type, and the amount of fluids which is being consumed, you probably can just give lifestyle changes, and that would take care of the lower urinary tract symptoms. If you do decide, based upon history and physical examination, that this patient needs workup, EU guidelines suggest that renal function tests should be done, because if your renal function tests are normal and there is no history suggesting any upper tract disease, you probably don't need to do an ultrasound or any imaging of the upper tract. Urinalysis is extremely important. It's a very simple, very cheap test, and it can tell you so much about what's happening in the urinary tract. We know that at least in our part of the world, and also increasingly in the Western world, because of the kind of food that we eat, the lifestyle that we have now with very little physical activities, diabetes is endemic, at least in our part of the world. And I see that in US, and I'm sure very similar trends must be there in the UK as well. So it's important that if there is a family history or there's something else suggesting diabetes should be checked. PSA is controversial, and that should be done as a routine test in all patients presenting with 50 plus presenting with lower urinary tract symptoms. And we'll talk a little bit later about this PSA. The post-void residue estimation is important, and it's important from various standpoints, although we know that the PVR estimation does not accurately tells you or correlates with the symptoms. Uroflowmetry, I think, is extremely important, very unfair to do any intervention without at least doing a basic non-invasive urodynamic like uroflowmetry. And the combination of post-void residue estimation and uroflowmetry give you an excellent idea of what's happening to the lower urinary tract, and they may help you in deciding whether further urodynamic evaluations is required. And invasive urodynamics is the ultimate in terms of investigation and making a diagnosis of BPH. Now, we have audience available, And this is a little questionnaire, this is a little MCQ about the use of questionnaires. So my question is that do you use questionnaires? Do you use it occasionally? You hardly or never use it? If you use a questionnaire, do you use IPSS score, the ICIQA male LUTS score, or both? So you can vote now, and we will have some idea of what's happening and what is the practice pattern. So you can write in the chat box, you can select more than one items, because if you are A or B, okay, so we start receiving some answers. It's good to see that at least some of you are using questionnaires, and I'm sure vast majority would be using the IPSS score, which is relatively easy to conduct in a busy clinic compared to ICIQ. So we have quite a few responses actually. Yeah, so we have a lot of A's, which is very good. And again, we have quite a few C's as well, which means that people are using, Ananda, they are using questionnaire, which is good.
Yeah, correct. That's good. At least basic IPSs they are using. That's quite good. Yeah.
Wonderful. Okay, so let's talk a little bit about the two types of questionnaires. We have IPSS, and it's, as you know, is an 8-item questionnaire, 7 items assessing the symptoms, and the last one is assessing the quality of life. If the score is 1 to 7, it's mild; 8 to 19 is moderate; and greater than 20 is severe course. So immediately, if your nurse has given the IPSS score to your patients waiting in the waiting room before they come and see you, you have the IPSS score in your hand before you even say hello, hi to the patient. So it gives you a fairly good idea of what's happening. And IPSS, we have done the validation of IPSS in Urdu, which is the vernacular in our part of the world. And I'm sure that there are various validated translations available in quite a lot of languages. I think there's over 30 languages that IPSS has been. So language is not a barrier, so it doesn't have to be in English. Compare this to the ICIQ male LUTS. It's a relatively more elaborate and major distinction is, although ICIQ has many types of questionnaire, the ICIQ male questionnaire is not only assessing the lower tract symptoms, but also the incontinence. So it is scored from 0 to 20 for the various 2 subscales, and 0 to 24 for the incontinence subscale. So essentially, this is more important, at least in patients who have some element of incontinence. So at least in those patients. But there are so many other advantages of ICIQ, which at least should be done in the academic centers. So recommendations from the guideline panel is that a validated symptom questionnaire should be used in the initial assessment of the male LUTS, and at least before you initiate BPH treatment in patients. Now, this is a study done by one of our colleague, Mazhar Mehman, published in the Brazilian journal about the VPSS. So this is for patients who do not have command over either of the languages, either the English or the vernacular, and they would do this rather simple VPSS score, which means that you just tick on some of the important parameters. It's not a complete score, which doesn't assess everything in IPSS, but provides you with a very basic thing. So rather than not using it and saying that the patient cannot read, you would rather use this VPSS, and your nurse can simply guide the patient in a matter of minute or two, and they will be able to fill up this questionnaire. And we found that it correlates very well with the IPSS as well as with the later workup of BPH. So anybody interested, they can go and read this article. As I've said, for ICIQ male LUTS questionnaire, it is assessing the frequency, severity, and quality of life on a scale of 0 to 21, with 4 scoring categories from 1 to 5 for slight, 6 to 12 for moderate, 13 to 18 for severe, and 19 to 21 for very severe symptoms. So, as I've said, this is perhaps a more extensive scoring system, should be used at least for academic centers. Now, what about PSA? One of the consultant, I forgot his name, he was a pretty famous urologist in Leeds. He used to say that PSA stands for patient stress and anxiety. And he is, I think, so right, that once you have done, you have opened up Pandora's box. And all the recommendations and the guidelines and the testing and the MRI scan and this, that, and other will initiate. And maybe in 3 months' time, we'll tell him that you don't have anything, you have BPH, and we'll keep treating you with alpha blockers or any interventional treatment. So it's important that PSA, whenever it is done, it should be done with a little explanation to the patient. People who come and who wish to have it done, obviously that's a different category. But those who are not decided, you need to explain that it may open up a series of tests. Its value in BPH is also established, and so values over 1.4 and 1.5 in some studies is more indicative of presence of BPH, because we know that the PSA is not just produced by the cancer cells, but every prostatic cells, although the ratio of PSA produced per gram of tissue between BPH and prostate cancer is 1:10. So the cancer cell would produce 10 times as much, the same amount of prostate tissue, benign versus malignant. So obviously that it's a diagnostic and screening tool for prostate cancer, although it has its fallacies. And we know that PSA monitoring is important in patients who are on alpha reductase for more than 6 months, where the PSA values has to be doubled in order to assess the risk of prostate cancer. So in this interesting work, serum testosterone levels and PSA levels are significantly associated in the multivariate analysis with the prostatic volume and the chances of development of BPH. So it has its value in the diagnostic workup of BPH as well. The recommendations from the EU guidelines is that PSA should be assessed if it is going to change your management. So if you have a 82-year-old person who presents with a 3-month history of low tract symptoms, which are moderate on the IPSS, you probably would not change the way you manage this patient if you do a PSA or you don't do a PSA, and so on. So if it is going to change the management plan for this patient, yes, you do PSA. If there is a chances of risk, and there are various risk calculators available, looking at the history, digital rectal examination, some of the other biomarkers, and that would tell you whether the chances of development of prostate cancer is significantly high in this group of patients. So you would definitely do PSA-based assessment. Major PSA, if it assists in the treatment decision-making process, as I have said, but counsel the patient that PSA testing has its implications. And a raised PSA test is going to open up a set of new evaluations. Post-white residue, what you need to remember are 3 values: 50, 150, and 300. 50, less than 50 in majority of men under 70 years is a normal post-white residue. So anything 50 or less is something that you should not think too much about. 150 is a significant PVR. So 50 to 150 is somebody that you probably may like to reassess and do another test, because PVR are very variable and have subjective variation. Anyone who has greater than 300 ml of PVR and the patient has significant symptoms, this gentleman is likely to require invasive urodynamics to make sure that there is adequate detrusor function before any interventional treatment is indicated. Obviously, it would indicate significant obstruction, and it also indicate presence of detrusor dysfunction, because if you have a poor detrusor, the PVR keep on rising, and anything values more than 300 is usually indicative of detrusor dysfunction. However, the presence of PVR does not correlate with symptoms. So it's not necessary that patients who have got high PVR are likely to have higher symptoms scale. So the recommendation coming from the EAU guidelines is major post-void residue in the assessment of male LUTS, and there is strong recommendations. So PVR estimation is extremely important. And as I've said, that patients who have a PVR of more than 150 are the one in which antimuscarinic agents should not be used. The antimuscarinic monotherapy is not indicated. Probably, if it is absolutely necessary, beta 3 agonist can be used in this group of patient. Okay, let's come to uroflowmetry, and let's run a little survey. Do you occasionally use access to uroflowmetry in your clinical practice, or you routinely do it in all the patients, or you do it in selected patients? Okay. So, Ananda, if you're seeing the results, I think it's very encouraging, because
Yeah.
I am 30 years practice in urology in Pakistan. And when in 1998, when I had full credentials, there were, I think, not more than 15 to 20% people, urologists in Pakistan, were using uroflowmetry.
Correct.
Even for interventional treatment. So it's very encouraging that uroflowmetry is now available in majority of institutions, and it's being actively used by at least our younger generation. So
Correct. Yeah.
okay, so if you do use, and as I've seen, majority of you are using uroflowmetry, do you use it before starting medical treatment, during the follow-up medical treatment, maybe say once a year, during follow-up on every visit, say if they're coming every 3 months to see you while they are on medical management or expectant management? You use it before intervention, or a combination of A and D, that before starting medical treatment and before intervention? Okay, so that's interesting. It is E for almost all of them.
Yeah.
Very happy. Very good. Thank you for your response. So, what is the evidence about uroflowmetry? Well, unfortunately, maybe because we have not done a high class study, because we know that it makes clinical sense to do uroflowmetry. So we do not have high quality evidence that uroflowmetry is important in making the diagnosis. But I think for me at a personal level, and I will take Dr. Kumar's opinion as well, is that it gives me a lot of information before even I start thinking of medical or surgical intervention in these patients. And for no surgical intervention, I would go without uroflowmetry. Anindya, what's your opinion?
Yep, I entirely agree. We are treating the patients based upon the symptoms what they come with. So that is very subjective. Say for example, if we have a power and give a same quantity of symptom to patient A and patient B, after 1 month if you see them, patient may get lot of suffering due to the symptom, while patient B may able to tolerate it. They may think that it's due to the age. But Euroflowmetry will clearly point out the exact problem depth. So Euroflowmetry is the objective way to measure. I will say if it is available free of cost, like for example in a government setup, to perform them in the baseline after medical management, before and after surgical intervention, so that you can document quite clearly how the patient improved objectively. But in a private setup, if the patient is not affordable, whenever there is a change, like after TURP, patient not improving, after medical management, patient not improving, it's better to do at least one measurement so that we know that the patient symptoms are truthfully objective blockage.
Wonderful. Yeah, I totally agree with you. I think this is the simplest, cheapest test that will objectively assess the patient's symptoms. Are they related to BPH or not? So, although the recommendation is weak, but still it makes a lot of common sense to do uroflowmetry. Now, based upon various urodynamic parameters, we know that we have Siroki's nomogram, and these nomograms are often there whenever you do basic urodynamics, and it uses the voided volume plus the post-void residue. And these nomograms, along with the Liverpool nomogram, which also assesses the voided volume as much as the PVR and the so both of these nomograms are extremely important in telling you whether your patient falls into an obstructive category or as an unobstructive category. The Liverpool nomogram is validated for patients under and over 50 years of age. So you can use these nomograms for different age groups, and you have to specify which age, and automatically it will calculate whether the patient is falling into obstructive or unobstructive category. In healthy men younger than 50 years of age, you need to remember that these nomogram has a little caveat, and that micturition may be affected by ejaculation. So those men who have not had sex or ejaculated in the last 1 week versus those who have in the last 3 to 4 days, there would be a difference, and you may misdiagnose obstruction. So this part of the history is also important. And obviously there are certain racial differences as well. So these nomograms are mostly validated in the Western population, particularly for Liverpool, the British population. So this is for the for men who are above 50 years of age, where the most important parameters is the Qmax. If it is less than 10 mils per second, it is considered as abnormal. Now, UFM is not without certain interpretation related limitations. There are certain artifacts. It's important that your patient should be voiding between 150 to 600 ml of urine to make the correct assessment based upon uroflowmetry. For patients who have low Qmax, it does not invariably means that there is bladder outlet obstruction. It could be due to poor detrusor function. So this is something that you cannot really make diagnosis based upon the uroflowmetry only, and the PVR becomes extremely important besides the rest of the history about various medical condition, and diabetes, long-standing diabetes, one of them, which results in diabetic cystopathy. So under destructor is something that you cannot, so you need invasive urodynamics. Patients who have less than 15 ml per second Qmax, they could be physiological compensatory processes, so it does not exclude presence of BPH. So again, it underscores the point that your history physical examination and PVR estimation along with uroflowmetry. So just the Qmax value is not really enough to make. While you are looking at the graph, which is after Qmax, the most important thing, it's important that you should be aware of various artifacts. There is a difference, and there have been various studies, but there is no clear conclusion about sitting versus standing uroflowmetry, and if there is a better way of which is better. So we still don't know for sure that is it better to do it in a standing or a sitting position, although many comparative studies have been done. Now, some men move back and forth across the funnel, which is called the WAG artifact. Now, WAG artifact is something that happens because you are moving the stream, and as a consequence, there is a sudden rise, which is for a very short period of time. It's about less than quarter of a second. And these WAG artifacts can give you a wrong reading on the Qmax, the printout that you get. So it's important that you look at the graph and correlate what is an actual Qmax. So the Qmax here, if you can see the bottom diagram, is not 23 mils per second as would be stated in the printout, but it's more close to 19 ml. Anything which lasts for so short a period of time has no physiological value. So you can disregard the 23 ml per second Qmax that is coming in the printout, look at the graph, and make a correct assessment of what is the actual Qmax in this patient. Some people do the squeeze and release of the penis, and that can result in certain artifacts and can give you a high peaks like the one that you're seeing with the red arrow. Again, this is due to the movement, and you should disregard that. The knock artifact is that if you accidentally knock the funnel, it can produce an artifact like the one that you're seeing in these diagrams C. Now, as we know that the Frank-Starling law within the physiological limits are followed when we are looking at the ejection if we're looking at the uroflowmetry. So the higher the volume and the higher the Qmax, but within physiological limits. Similarly, if you have very low volume voided, again, there would be significant variability, and that may not assess. So anything less than 150 ml should be repeated because it is not giving you the correct picture. Anyone who has voided more than 600 ml, probably in some situation it would be okay, but in some it would not be. So it's important that you should disregard that and order another one. As I've said that the Qmax of 15 ml would sometimes exclude obstruction, but not in every situation. So it's important that you look at some of the other parameters. I'll rush through some of these slides. I'm running out of my time. So patient who cannot void, these are some of the indications for doing invasive urodynamics. So this is uroflowmetry is a non-invasive urodynamic, but invasive urodynamics with cystometrogram and voiding cystogram or video urodynamics is indicated in situation where the patient cannot void less than more than 150 ml. The previous failure, as Dr. Ananda pointed out, of invasive treatments, post-void residue greater than 300 ml, patient age is less than 50 ml, where you should be very, very careful in making a BPH diagnosis, and patients who are or older than 80 years of age. Again, it's important that you do urodynamics before any intervention. Okay, so these are one of the three things that you may observe when you're doing the voiding cystometrogram, in which you can have low detrusor pressure and high Qmax, which obviously is unobstructed. low detrusor pressure and low Qmax is obstructed. And if you have high detrusor pressure and low Qmax, it is likely that the patient may have a hypocontractile detrusor. These are the Paul Abrahams described the bladder outlet obstruction index and the bladder contractility index, which probably gives you a better idea of what's happening. And these are essentially telling you what you need to have is the data on detrusor pressure at the Qmax. So voiding cystometrogram or pressure flow study needs to be done, and it will give you a fair idea of where you are falling based upon these indices. And I'll just skip some of the examples that we have. In the interest of time. So the basic thing to remember is the detrusor pressure and the Qmax will give you an idea about the level of obstruction. Another important thing before I conclude my talk is that nocturia, which is considered as one of the most important symptoms in the diagnosis of BPH, could be due to a myriad of factors. So it's important that you took a good history and make sure that this nocturia is not, or frequency, daytime frequency even, is not related to some of the other factors. And it is particularly important in patients who have congestive cardiac failure. They may have nocturnal polyuria, and most of these patients would not require anything more than using vasopressin, and that would sort out majority of time, or reducing their fluid intake during daytime, or giving daytime mild diuretic like a thiazide, so that their preload is decreased in the evening. So I'll stop here, and in fact, I'm not going to touch upon this, and then there's going to talk in details about all these modalities and the level of evidence available and where is indicated, what is indicated. So my conclusion is that move in a stepwise fashion. Invasive urodynamic is the final word in the diagnosis, but not before you have done a good physical examination, taken a good history, and evaluated your patient with basic workup. So thank you very much for your attention.